Morning and welcome. Since everyone is here, might as well get started. Thank you all once again for joining my colleague Ikram and myself this morning for a discussion on convergence of technology, policy, and practice as it pertains to the evolution of delivery systems for better serving the American people, particularly at a time as we enter this new age of artificial intelligence. There is no question that we are seeing the start of the fifth industrial revolution. And I'm sure Jaideep may agree or not agree, he's the technologist over here, but I believe it is the fifth industrial revolution. And establishment of, just to share with you once again, which I've done one-on-one with you, is the genesis of the establishment of Health AI Institute is a result of conversations that we've had with a broad array of stakeholders, providers, payers, policymakers, technologists, medtech innovators, researchers, educators, venture capitalists, funders, and more. There is a feeling of frustration that a lot of siloed conversation is going on, and we are moving farther and farther away from, from our ultimate goal of patient-centeredness, providing care that is safe, efficient, effective, and high value for the American people. We know who we serve, but at the same time, looks like in this new era, we're just moving away. There's less and less of integration. So what we have heard is what is needed is an ecosystem view that includes the entire healthcare, health and life sciences all together, so that we are on the same page and not miss the opportunity this new technology, artificial intelligence, provides us to innovate and define by design the future, as opposed to stumbling into it and struggling all along. There needs to be a more planful approach. Having said that, what we are looking to achieve today is with you, industry experts, people who are out there taking care of the people in one form or another, are involved heavily in this new technology, artificial intelligence. What we are hoping to do is ask you to share with us your actual hands-on experiences where AI has been applied and is working. Also identify innovation opportunities, the far out thinking that you may have based upon what you have seen, heard, and are assessing based upon your work, as well as your understanding of the bigger, wider lens. And the third thing we want to accomplish is, as we close out today, is to hear from you as to how to navigate, how to manage this unintegrated environment, if I may call it so, and make it more integrated for again, to better serve the American people and the American patient. So with that, I would like to get us started. You all have seen each other's background information that we sent you. But nevertheless, I think it'll be good to go around this virtual table, take 5 minutes or so to introduce ourselves, our passion, most importantly, with AI. And before we do that, I'll stop and say, do you have any questions of me as to what we are looking to accomplish? Yes, no, maybe so, none? Okay, Deepti, then why don't you start? We'll start with you. Do you feel very passionately? So tell us about your passion
Sure.
about.
So, a little bit about myself. It's so great to be among all of you. I am Dr. Deepti Pandita. I am a physician by training, still practice in internal medicine at the University of California, Irvine. A transplant from Minnesota. I was in Minnesota for over 20 years, worked in various capacities, was affiliated with the University of Minnesota as well. But my last job was the Chief Health Information Officer for Hennepin Healthcare in Minneapolis. Currently, my role at UCI Health, I lead AI governance here. I am the Vice President of Informatics as well as the Chief Medical Information Officer and a professor in the Department of Medicine. I also am on the AI governance for the entire UC system as a member. And as a UC system, we also participate in other coalitions like CHAI, which I'm sure everyone has heard about, the Coalition for Health AI, as well as Valid AI, which was born from UC Davis. So that's a little bit about my background. My research background is mostly digital disparities research, and I've published on that. I also dabble in health policy because a few other hats I wear is I'm the physician chair for the HIMSS Physician Informatics Committee, and also the chair for American College of Physicians Medical Informatics Committee. And as part of my ACP role, we did publish article very recently, which I can post in the chat shortly, about the role of AI in the provision of healthcare, which has been a policy paper published by the American College of Physicians, which is the largest body of practicing physicians in the country. My passion around AI is mainly around how do we use AI tools to decrease clinician burnout. And by clinician, I'm including nurses, physicians, anyone in the care delivery area, not just restricted to physicians. How can these tools augment care delivery and reduce the burnout factor while improving efficiency and proficiency and not creating any disparities? So ethically and responsibly use AI without creating any disparities in the healthcare arena. And at the same time, we have a huge workforce shortage. How do we create retention by deploying these tools? And already we are seeing a dent. We have deployed a lot of tools here in my own area. I do have a role in our Center for Innovation. We are using AI for ambient listening to document, the physician-patient conversation, and not only just document, then we can translate it into patient's preferred language, which really is huge because that is where the, health disparities, component comes in. Also, there are about 600 or so use cases just in the radiology sphere alone, in various stages of innovation. Some are actually working well, some are not so good. A lot happening in the prior authorization space, which is a huge burden on clinicians. So use of generative AI in prior authorization. What I do want to see, which is not happening yet, is the continuum of AI. So starting from the medical school to the training to practicing physicians in terms of curriculum development, education, that whole spectrum of AI from inception so that the physicians are thinking about AI. What is happening today is we are providing them ad hoc tools and saying this is AI driven. I mean, whether it be predictive analytics tools, administrative tools, whatnot. We are not actually educating them as to how these tools are actually developed, vetted, so that they can build trust in the tools. And that is where the biggest problem right now is. People don't have trust in the tools, and it falls on people like us to keep saying, oh, we are building the trust. And that trust will come from education and transparency. So I think that's where the advocacy part comes in and becomes very important. So I'll stop there, and I'm happy to answer any questions.
Thank you, Deepti. Jaideep, a little bit your background and your passion. We can't hear you.
Sure. Hi. Yeah, can you hear me?
Yeah.
Oh, well, good morning, everyone. I'm Jaideep Srivastava, and I'm a professor of computer science and engineering at the University of Minnesota, and been here for a long time, my first job. And as I tell everyone, my commitment to the University of Minnesota is beaten only by my commitment to my wife. We've been married for 37 and a half years, so 36 and a half at Minnesota. And and I'm a transplant the other way around. Got my PhD at the UC up in the north and moved over here. Many years of experience in sort of all data aspects of computing. So from databases to AI, machine learning, and now a lot of my work is, I would say, half and half fundamental AI kind of stuff, and other half is applied and mostly in healthcare space. More recently, I have, I guess I can claim some creds. IIT Kanpur, which is my undergrad alma mater, just started a new School of Medical Sciences and Technology, and they officially appointed me as a visiting faculty over there. So because they have a lot of interest in things like AI, biomedical engineering, and things like that. So a lot of interest in the area. I guess from a technology point of view, so Deepti, a very good summary of all aspects of from a physician perspective. From a technology perspective, I would say that there's I'll probably break it down into a sort of three parts. One is that there are many things that physicians do that they don't really want to do. Like, let's say listening to a patient describe what they are feeling is a great thing. Make patient connection. You're collecting information. You make a patient connection, but having to transcribe all those notes into Epic is not something that physicians want to do, or for that matter, any medical professional. So there's, as I said, essentials that need to be done, but medical professionals don't want to do. So that's sort of one bucket. A second bucket is the part where there are things that you want to do, let us say, make a decision, whether it is diagnosis, prognosis, therapy, whatever else it is. Is it a rare case? Is it a common case? Acute, chronic, whatever it is. Over there, clearly, physicians drop on their knowledge, experience, training, education, and the additional knowledge upkeep that goes on. But uh, there is a vast source of information out there from all the information that Epic has about every hospital system that they're managing, or the vast research information that is there in the NLM, PubMed, everything, right? So the question is, how can that be brought in to make the decision making better, especially for the newbies, those who are just starting off in their practice, don't have years and years of experience. So that's sort of a second category. And the third is what I would call is almost invisible, except to the hospital administrators, is making all the trains run more efficiently and on time. So the hospital system is a major, operation, like an airport or whatever else, like a factory. And I mean, I know some of them are bad sounding analogies, but in a sense, from a systems perspective, that's what it is. So to make sure that there's less wastage, there's things are done more on time, better efficiency, and better care. I think all of these are areas where technology, and especially AI technology, can help. Okay. And then I guess, as even I'm talking about, I would put in a fourth one, which is that people, that is, um, health information about an individual is collected largely when we touch the healthcare system. So I visit a hospital, I call up the nurse line or whatever else. That's when information about me is collected. But except people who have pacemakers, at least about their heart, you can get information all the time. Okay. Fortunately, not everyone has a pacemaker. Uh, and fortunately, we spent 99.5 or 99.9% of our time outside the hospital. But that what we are what is happening to us in the rest of our lives and so on is also has serious impact and significant impact on our health. But information about that is generally not available, except now it is becoming. So I would say there's these four big buckets that I see of how and where technologies, especially because we are talking so much about data collection about all of these things, and AI is basically a way of making sense out of all of that data. It has potential in all of these different areas, and there's innovation going on in all of these, and it'll keep going on. However, to what degree those innovations are accepted, to what degree they are used towards better quality of care, better health, better efficiencies, reduction of cost, whatever the desirable metrics might be, equity as well, uh, depends a lot on exactly the kind of things that you said about building the trust, having the education, and all those aspects as well. And of course, having the appropriate guardrails of all kinds, from making sure that from a healthcare perspective, there's a guardrails, but also AI technology is very creates fear. Is it going to affect my job? Am I going to get outdated? So there have to be the appropriate attention paid to all of these things. Otherwise, the trust will not be made.
Having said that, Jaideep, let me move to Barry. Data comes up again and again. So, as a cybersecurity expert, what you're thinking from a data perspective?
Thank you, Gopal, and wonderful to meet everyone this morning. I'm looking forward to
And first, your
productive.
background a little bit.
Yes,
for
absolutely.
everyone.
Looking forward to a productive conversation this morning. By way of background, my career has been focused in technology and security, but most relevant to our discussion here, I was the first CISO, Chief Information Security Officer for the Minnesota Department of Human Services, where Gopal was our esteemed state CIO, and our paths crossed there. And after my time with the state, I was then the first CISO for Fairview Health Services, now called M Health. Of course, we don't know where those organizations may go into the future. So sometimes it seems like things aren't doing that well. But in my role with Fairview, it was a multidisciplinary role because we not only were responsible for the technology and security at all the Fairview community health systems, which also included Ebenezer, and then eventually Health East and others, but then also on campus, the med school, UMMC hospitals, University of Minnesota physicians, and all the other pieces there, as well as the research platform, and too many other organizations to count. It was really a multidisciplinary organization. So there are so many interesting questions going on with AI, and it has become such a buzz phrase. I should also mention in my current role, I am a executive partner with Gartner. So my role is to work with chief information security officers throughout North America, and actually wider than that as well from a time zone perspective, on security challenges. And most of the executives that I am working with are in healthcare. So there are many challenges that they have in those areas. Getting back to the sort of the biggest challenges for healthcare right now. Well, first of all, in terms of interest and opportunity, I really like what Deepti mentioned around burnout, because it is absolutely true in the clinical space, but it's true in the technology space as well. All of our high performing, high skill workers and executives are facing burnout, and it wasn't something that just occurred because of COVID. It was certainly happening well before that, and there are potential opportunities for AI to help, but it's hardly an answer. I just came from the Gartner Security and Risk Management Summit, which was held in Washington, D.C. a few weeks ago, and AI is such a buzz phrase. I was making the comment that as you looked on the vendor floor of all of the technology vendors there, everybody is well ready to sell you some AI. There were hundreds of them out there. Of course, 2 years ago, for those of you that know all the technical buzz phrases, all the vendors wanted to sell you zero trust. Well, now nobody's selling zero trust. Everybody's selling AI, and maybe 2 years from now, they'll be selling us quantum computing or something different, depending upon which way the wind is blowing. So I certainly don't see AI as a panacea. It's certainly not anything new. 40 years ago, when I started my career, I was working at research organizations that were working on AI. So this is not a new topic by any means. I'll make a quick comment on why I think it's become such a big thing in recent years, and it's not just the opportunity. I think there's three components. Number one, technology has improved. Most significantly, our chips and our ability to process. The flip side of that is we know that AI can be extremely costly from a dollar perspective and from an environmental perspective, in terms of the amount of compute power that's needed to do some of these, to carry out some of these operations. Secondly, we've now got, with Gen AI, which is, I guess, maybe the newer part, again, not brand new, but certainly newer, it gives us shall we say, a friendlier interface into AI, and that helps make it available for folks. People are able to actually use the tools. And the third piece is, again, the ChatGPT piece here is what I would call the democratization of AI. It's now suddenly become available to everyone, and people have been, it was the end of 2022 when ChatGPT came out. I think it was in November of 2022. And all of a sudden, everybody was excited about AI because they could suddenly use it and maybe not understand it, but at least use it. And people are using it for all kinds of jobs across the board. So I think that has been the evolution or revolution that has really got us here. Couple of pieces then. On the data side, I think we see a lot of overreactions. We have a lot of organizations getting excited about AI because it's a new thing. We have a lot of security and technology folks that are maybe afraid of AI for a variety of reasons. People are concerned about advanced attacks. People are concerned about data loss. There's so many different issues going on. From an advanced attack standpoint, we are in an unfortunate time here, which has been going on for about 10 years, where healthcare is just too easy a target for the attackers. So as we think about AI advanced attacks, that is not my concern. It's not what I'm working with the executives that I'm working with on. We sort of I don't want to say this is a joke, but it's a joke among security folks that we would say that no attacker is going to waste an advanced attack on a healthcare organization, because all you have to do is send somebody a link and they'll click on it and you're in. Or there's always going to be an account that's open. If we look at some of the recent big healthcare attacks, Change Healthcare, Ascension, Lurie Children's, Fred Hutchinson Cancer Center, half of them were blamed on nation state attacks, and these were all trivial attacks that a kid in their basement could have pulled off. Now, was the attacker maybe associated with a nation state? Could well be, but these are simple attacks. These are not difficult attacks here. So the point is that AI is neither the enemy nor the savior here from a security perspective. It's not the enemy because it's not the AI enhanced attacks that we're seeing, and maybe we will in the future. But again, the attackers are not going to use their advanced techniques against healthcare. And then from a savior perspective, the tools just aren't there yet, and the marketplace is such that anyone who's responsible for security is just faced with confusion. They don't know which way to go. There is no product that you can just buy from any vendor that is going to fix problems, and we've still got the same problems that we've had for decades. So it just leads to an environment of confusion is part of the problem here. So if I had a magic wand, it would be wonderful to be able to get rid of some of the vendors that are just saying AI because it's the thing to say right now. And if we could get some of our vendors, and maybe it's Microsoft, maybe it's others, focused on solving the real problems, because and I know we'll talk about this in a bit, but I think the opportunities, especially in healthcare, are fantastic, astounding. Organizations just need to assure that they understand, why are we getting AI? We're getting AI because it's the exciting new thing, or do we have some specific use cases like ambient digital scribe that's been mentioned, which is phenomenal, incredible technology. Can we, Deepti, you said it again too, you said about clinicians not having trust in the tools. So what can we do to get over those kinds of barriers? I think those are the things that we have to sort of focus on, and the security folks will get on board.
Thank you, Barry. Renben, we want to hear from you. What's the latest on the policy side? Tell us a little bit about yourself, your work, and what you see as the lay of the land on the policy front.
Sure, thank you. It's been really great listening to everyone's background and introduction. I can see that everyone's here very experienced in the healthcare field. I myself am not. I am coming from a very heavy policy background, so hopefully I'll be able to share something that's useful, and also to hear and learn from experiences as well. So I'm Renbin, and I'm actually originally from Malaysia, also a transplant, but I did a world tour before landing here in Minnesota. So I've lived in China. I've also lived in Denmark. And then I, 9 years ago, moved here with my husband and family to Minnesota. And then it was a few years ago that I decided to go back to school, to Humphrey School of Public Affairs at the University of Minnesota. And this was primarily driven by the, at that time, it was primarily driven by all the debates around social media and mobile devices. And I could see that there was a policy lag in that area and how, regulators were grappling to try and, manage the issues that were emerging from it. So I decided to go back to school, but also I realized at that point, when this was before AI exploded, that AI was going to be a huge, foundational element in many, many applications across sectors with a lot of potentials in many domains. And I wanted to go back to school to be able to come up with policies that could address AI and prevent or reduce this type of policy lag in that area. So at the time, I was the only person talking about AI. No one knew what it was or care about it. And so it's a very lonely time, but it was really fascinating at that time even to do the research and study on what was coming and the potential policies that we may need. So so right now I graduated, that was back in 2020, before the ChatGPT happened, 2022, yeah. So since then, there's been a lot of work. I am currently an independent AI policy researcher. I am doing research with a couple of think tanks in DC. So one of them is the Center for Security and Emerging Technology, affiliated with Georgetown University. So there I'm doing a very specific series of research on AI incidents, looking at AI harms and risk, and how to come up with incident reporting frameworks to monitor these incidents. Then next, I'm also working with the Center for AI and Digital Policy Group. Now that center is more specifically towards providing recommendations to governments and international bodies on AI policies and guardrails that are needed. So most recently, for example, that I worked together with them on providing some recommendations to the UK Information Commissioner Office on data protection policies around generative AI. Next is, well, we were talking about passion in AI. So what I see is that it is a very powerful tool that has great potential to be used in a lot of different domain sectors to help achieve the very aspirational sustainable development goals listed out by UNESCO, for example, but to want to ensure that we can develop AI safely towards these goals, because we have seen a lot of major incidents in the past with other technologies, specifically nuclear energy, where there was great potential, but because of a few incidents and then the public fallout and then loss of public trust, and we talk a lot about trustworthiness in AI. So this is something that we're working very hard to avoid. Also to come up with the safeguards, as some of you mentioned, that is necessary to help guide, the safe development of AI towards the goals that we foresee. And also, I think personally, I am also trying to increase AI literacy. This is part of also something I'm very happy about and excited for. Is this fall I'll be going back to Humphrey to teach actually a class on AI policy, ethics, and issue. So bringing some of that back, AI literacy, to help the future generation, people who are going to be working in policy or just career in different areas, to understand the applications, the uses, and also the limitations of AI, and understand how to use it responsibly. And also to push for more democratic participation in the development of AI.
Thank you, Renvin, appreciate it. Ikram, you want to take a moment to quickly update us about your background and your passion, so we can get into some discussions over here.
Thanks, Gopal. Very good morning to everyone. I'm Ikram Khan. I come from a small town near Delhi in India. I moved a couple of years back to Minnesota with the reasons to understand the Minnesota health ecosystem, seeing that some of the challenges which I come from the other part of the world, and how I can find it. So I come from a mainly of a clinician side, and then moved to public health side, and I started my career more as public health policy, with working some of the public health think tanks, including World Bank and United Nations, to design some of the policy intervention in the developing countries. After working for some time with bureaucracy and bureaucrates, I find that this is not a very fast moving thing. And I was getting frustrated with the pace, and I moved to more of creating health system models. And I was one of the first ones to leading and building the private health ecosystem in the one of the poorest state in India, launched that from scratch, and then moved to lead one of the largest chain of primary healthcare as CEO. That was globally acknowledged by Duke Medicine, McKinsey, and World Economic Forum as a global health innovator. And then later I moved and launched my own venture, again, health system for the rural side. And after working for a decade during pandemic when government of India put blanket ban on all the health activities, I started realizing that if I will keep creating these health centers, that's going to solve the problem of the health accessibility and affordability. I found that the answer is no, because the huge resource constraint, which Deepti and Jaideep mentioned, and the quality is again a big issue in that. So with matching the health resources with need of that, we need some kind of technology augmentation in that way. And I find that AI could be one of the solutions supplementing that. And with that thought, I started looking around the world that where I can go and find and learn new technology in great ecosystem, health ecosystem, and Minnesota came very appealing in that way. Have a good ecosystem like Mayo here, which is globally famous, as well as largest payer group, UHGs here, and a lot of medtech companies like the Boston Scientific and Medtronic, which was got a lot of limelight during pandemic, supplying ventilator. And that's how I moved to Minnesota, and I started working with the TechCom office at UMN, along with my MBA at Carlson. So we work with so many innovators like Jaideep and Deepti to commercialize them, and that's how we learn that's what different technologies are working here. And during that process, I moved to take as a interim CEO role of one of the technology company, trauma analytics company, which works on AI part, and that's what I'm working currently. And I see that some of these technologies which is getting invented, including AI, how we can solve the global shortage of the human resource, supplementing them to inaccessible population worldwide, and provide them good care. And that's what I'm looking forward, and that's what my passion to using technology for the care of the patient.
Thank you, Ikram. And by the way, feel free to ask each other questions. But Deepti, I want to go back to you. For this conversation, I want to make patient and the clinician as the center, as the bullseye, because if that is done well, everything else needs to support it. So drill down a little bit more crisply on some of your observations, and just start with the patient and the clinician relationship, and what the challenges are, and what AI needs to do to really bring effective solutions that may not be in place today.
Right.
Maybe some blue eyes to the sky thinking as well.
So I would actually even take out the clinician from that equation. I think in the bullseye would be the patient in the center, because at the end of the day, that's what we are trying to do, provide cutting edge care, which is patient centric, and meet the patient where they are. Because ultimately, we are all patients in the ecosystem of healthcare. So if you keep the patient in the center, clinician is just one sort of cog in the wheel. There are access points. How are people going to have access to care? Right now, this whole model of care into the health system, so you come into the walls of a health system to get care, that is actually a fallacy, and it's not working, because the 8 to 5 model, that's the same time that the people are working and the same time that the clinicians are working. If you are sick, you go into the hospital, you are again inside a wall. So I think the first thing we should think about is, how does this wall, which we have created, how do we break that down? So how do we create models for access to care to meet the patient where they are, when they need it, where they need it? So that's number one. And this is where digital tools come in. And this is where predictability, which we can use AI for, comes in. Can we predict that this patient who has this disease process is going to deteriorate in this time frame? So we are proactive. We dispatch care to their health, to their home, dispatch a lab service to their home. Do we have devices that can monitor and tell us that they are likely to deteriorate in this time frame? So we can surround them with those services in a manner where they don't even have to come in. So that's one aspect. Now, the second aspect is if they do need to come in, how do we provide access? Can AI tell us where are, because most health systems now are very large. So can AI tell us that, oh, if the patient even has this relationship with one provider, but that provider is, say, out of the country for a conference or something, there are gaps in the healthcare system where this location here has an opening and the patient can be plugged in there. Right now, that's a manual process. I mean, I can tell you from most healthcare systems, you pick up the phone, you're on hold for 30 minutes. How can AI show us that big picture of, for this patient, for this condition, there's availability here. So that's the second aspect. Now the patient comes in. How do we maximize that interaction time at check-in? Can the patient fill out a lot of those questionnaires which take up time at check-in, those long lines? Can those be done beforehand? Can AI take care of some of that? Because all the information is there in the EMR. Can AI sort of create synopsis of that information so you're not wasting time? Same with prior authorization, insurance collection, all that. All that should be automated. And right now, I can't emphasize this enough, most of that is still manual. I mean, banks have automated it long ago, but healthcare somehow cannot do it. Now you're again in the doctor's office, you're having an interaction. I mean, most people will tell you that, the patient, the physician is facing the computer or the nurse is facing the computer and the patient is sitting on the exam room table without any FaceTime. How do we just take out that? Take out that computer as the third wheel and just have an interaction where that ambient, ecosystem is capturing all that interaction. And then the note is created. So the physician can feel confident that now they can move on to the next patient without having to go back to their desk to, tinker with the computer and type or whatever they are using. Then from the patient standpoint, again, how can that next appointment be scheduled automatically? Oh, the physician, you listen to the conversation, suggested that you have labs today, a follow-up appointment in 3 months. Can that be automated? AI can do that, so how can we organize that in a manner that, again, you're taking that manual step out of the way so the nurse can move on to the next patient and not have to worry about scheduling the appointments and all that. And the patient doesn't even have to stop back at the front desk. And then the patient wants to know, oh my God, so much came my way during that interaction. What happened there? And that's all done through automated generated patient summaries in their preferred language, in their preferred reading level, and all that AI can do. So they have a clear set of instructions on what to do next. And then if they have chronic diseases, can we send them home with devices that are constantly sending us inferable, material? So whether it's blood pressure or breathing devices or sleep devices or whatever. Now, again, in that whole ecosystem, AI can help, but the health system should not have to take on the burden of deciphering all that data that's coming in. I mean, again, remote patient monitoring exists today, but it's too much data. How can AI help us just take the most meaningful parts of that data to alert the clinical team only on the most meaningful things, not this data bombardment that's happening today? So that's sort of, what I envision.
So, Deepti, if I'm listening to you, what I'm hearing is that there needs to be a deeper understanding on the part of all the stakeholders within the healthcare ecosystem to get deeper insights on the care journey, the patient care journey. Is that correct?
Yes.
Way to
Right.
summarize it?
And we call it digital patient journey, digital front door, whatever. It all exists today. It's just that all of that can be augmented with AI, which is the gap today.
So, Jaideep, I'll come to you and say that, okay, these platforms have been created, and maybe you can tell us a little bit about what Microsoft is doing and Google is doing in terms of these platforms. But how do you envision algorithms and app development? What would be some of the solutions? I'm just talking about care journey right now.
Sure, sure. But I think that Barry though has raised his hand. He has some comment he wanted to make. Okay. So yeah, no, I think Deepti, that's a great, the thing that you gave about the patient's care journey. In fact, let me add a few examples of what is going on. Uh, Not so much even at the technology level, more at the level of actual solutions. Obviously, and the solutions right now are point solutions. They're addressing specific problems that are being perceived by those who are offering them as the highest pain point right now. And then eventually, we might get to overall solutions. Okay, so a specific example, like, Deepti, you said about this whole ambient listening or ambient, so that the provider or the doctor can focus more on the patient to get more face time. Perfect example. But actually, what is even more interesting is that people, well, in addition to that, also what people are saying is, and I know I have talked to Epic, our next door neighbors, and they're saying things like, hey, we're thinking about, see, right now what happens is that in my charts, I can send a message, okay? But the message is replied to by a human, and therefore it's seen as a burden on the human side of the healthcare provisioning. And initially the idea was, well, restrict it to no more than one message a month or two messages a month. The idea, after that we'll start charging, and the idea being to stop people from sending too many messages. But if you turn the equation around and say, well, you know what, the listener is ChatGPT. Now you want the patients to send as many messages as possible, because after all, when I am at home, I'm sending a message, hey, this is how I'm feeling. That is a far more in real time, actual how I'm feeling, rather than a vague recollection of that when I'm talking to you when I show up a month later or 2 weeks later when I get my appointment, right? So the idea is that now with what can be done with that? Not just a reply, not only will ChatGPT give some kind of a reply or whatever, it has the potential to actually create a summary beforehand, the night before for you, that when I show up, you actually have a summary of what the potential things might be, right?
Yeah.
So that you
Yeah.
don't have to, you just have to get a little bit additional to that rather than a whole month of that. And in addition to that, the other aspect of it, let's add predictive modeling to that. So let us say, along with that, what I'm feeling like, and suddenly the thing flags and says, oh, maybe this person should be brought in before. They are going down a path where they're feeling worse than what they should have been expected. So maybe they need to be moved up, or at least maybe a nurse should call, and nurse practitioner should call and assess things as to how they're feeling. So maybe things like triaging automatically goes on. And then of course, once you add to that all these medical devices that are collecting data and so on, all of a sudden, in fact, a good friend of mine, Rick Kunz, and if you guys know of him, Rick just retired last year. He was the chief medical officer and the chief scientific officer of Medtronic. And the terminology he likes to use for this is moving from uh, episodic care to continuous care. And episodic care, again, and I'm sure that a lot of people have used phrases like this, but that's his terminology that I've seen, is that, right now, a health episode happens, and then the care episode begins in response to that. So it's kind of reactive to that. While suddenly it can go to being proactive, predictive triaging, all kinds of things. So those are the kind of things that I would like to that. So, the predictive modeling has helped over there, as well as things like, so Epic, for example, is thinking about doing those kind of things. So my charts may all of a sudden, they may say, well, send more information about yourself, not less, because it's helpful. So that's an example. And of course, on the side of things like diagnostics and prognostics and so on, there's all kinds of things going on. I personally, I'm glad you mentioned about sleep and so on, because Fairview Health System has a very active and one of the leading uh, uh, Institute of Sleep Medicine and Science, headed by Con Iber, who's a nationally recognized person in this area. And we have been working with them for a few years. And here are some of the interesting things. couple of things that we were able to do was this. One is that the definitive detection of sleep apnea is a polysomnography, but you have to go into the hospital or a clinic and spend a night there. Now the question is, but then if you get assigned a CPAP machine or one of these kind of things, all of a sudden, how accurately can you assess from that, which is a far less channel? We actually were able to show that using deep learning, you could predict, the at-home CPAP, if you will, at-home polysomnography based purely on CPAP plus deep learning gets to about 80% accuracy of in-clinic polysomnography. So that's one side. The second part was that even if supposing someone gets assigned a CPAP machine, a big challenge is therapy adherence. Say, the people just give up after a while. So they have all these programs like, well, call someone in after 3 days, call everyone after 14 days, call everyone after 30 days. And then, they have to talk to everyone. And roughly 40% of the people give up on it. But the question is, which 40%? And they have no clue. They're just using sort of, one size fits all. We again started using behavioral data from how long someone used CPAP, when did it turn it on, when did it turn it off, and so on. And that behavioral data, we were able to again build a model that has over 85% accuracy in predicting who is at risk of quitting. And the idea is you just focus on those people. And in fact, what it does now is it scores everyone whose therapy is being managed every single day and says, well, these are the ones in red color, you only focus on them. These are all green, don't worry about them. So things like that, all of a sudden, AI, which is collecting data from, the ResMed's CPAP machine or its usage pattern, all of a sudden starts giving things. And in fact, just to add one more thing, what was interesting was that, and this is the lateral impact of AI, we published the result about therapy adherence in a forum. Guess what? We heard from Merck. And I was talking to Merck and said, well, you guys don't make anything having to do with CPAP or any such thing. I said, oh, no. But we work in the area of childhood growth hormones. And we are also very interested in knowing who is going to quit, which parents are not going to be regular about giving their children growth hormones. We want regularity in that, because if that is not done properly, then eventually it has long-term consequences. And interestingly enough, it's exactly the same algorithm that worked in the behavior for CPAP therapy was the one that worked on early detection of those who are going to quit. So the point is, these were interesting. I just thought I'll give some point examples of how this kind of stuff like, out of the hospital data that is being collected has potential impact in better, diagnosis, triaging, prediction, therapy management, and so on. In fact, personally, working with that kind of data is an area of active interest for me.
Yeah.
So coming back, Jaideep, what you're talking about, data, right? And Barry, I'll come back to you in a moment. But Deepti, from your vantage point, you guys, when you're practicing this HIPAA regulation, which maybe some people say it's outdated, needs to be rethought in light of just this whole dependence on expanded data. What do you see?
So here is, I mean, Jaideep pointed out all use cases, which are very active use cases. I mean, I'm myself using ChatGPT for chat biopsy. I mean, we are co-development partners with Epic on most of these things. So, and Epic is a partner with Microsoft with ChatGPT usage. And so all these things are happening. But we have a very skewed view because, we are in academic medical centers where this can happen actively. Now, think of the healthcare ecosystem. You saw all the news about the Walgreens and the Walmarts and Oak Street Health, and all these are collapsing. Why? The reason is that healthcare still is a relational, field where everything depends on the patient-provider relationship, and those relationships run deep. So again, I'll come back to, yes, while all these use cases work and there's enough published and they are good, they all get us 80%, there. And healthcare is an area of zero, liability. I mean, there's a lot of liability. You have zero margin of error. Is 80% good enough using AI? And if it is, if 80% is good enough, is that the standard now? And these are not established standards. And that's where I think the biggest thing I grapple with on a daily basis is how do I tell my providers that you're using this, tool for a chart biopsy to know what happened, for the last 10 years and all that, and it's saving you 20 minutes a day. We have published on that. All that is good enough. But that one echocardiogram that ChatGPT missed, is that vital enough? And will that affect the patient's outcome? And people don't have trust. I mean, they'll say that was the most important echocardiogram I needed from that 10-year history. And GPT missed it, so I'm not going to use this tool. So and then that trust will come from more guidelines, regulations in terms of, yes, it is okay, 80% is good enough, or that, physician oversight is still needed. You talked about HIPAA. I think we still need to, we are gathering consent. So when I'm using two different ambient tools right now for clinic documentation. I still need to gather consent on a patient by patient basis. It takes a time to get that consent. Patients ask questions. Luckily, we have not had any patient, pushback, but still, it's on a patient by patient basis. When can we get to a stage where these things are just seamlessly incorporated into the healthcare ecosystem, just like we did with EMRs? I mean, now no one questions, why are you using an EMR? Because it was just, it's sort of the way to deliver care. So I think we are nowhere close to that stage, yet the technology is developing at a very fast pace, and the regulations and the guidelines have not kept up.
Is it possible that that practices from other industries can be incorporated? I'll give you an example. Dr. Gary Kaplan, he used to run a system in Seattle, and many, many years ago, he decided that he was going to take his board of directors as well as senior executives to Japan and get educated on zero defects. And they used the Toyota model to come back and start re-engineering their hospital systems and move the needle from 80% to closer to 100%. Because if the cars can aspire to be zero defects, why can't the delivery system aspire to be zero defects? Is that where your line of thinking is, Deepti, that there has to be, with new technology, an opportunity to rethink the delivery processes, re-engineer
Yeah,
them?
absolutely. Absolutely. I think, lean is a good example. We use lean in healthcare all the time to improve processes. It's just that lean is a slower way. You go process by process and improve. The technology is so rapid right now and so global, and people are very eager to deploy it in so many use cases that we are not moving fast enough. That's, I think, my challenge. Barry has been waiting very patiently.
If I'm hearing, Barry, please chime in. Sorry about that. We just didn't want to break this chain of thinking over here. But all of this, basically, Gary, from your vantage point as a cybersecurity person, it's a nightmare, isn't it?
Well, this is all very true, and now based on the ensuing conversation, I have a number of comments to make, but I'll start sort of on that one. I'll start on the HIPAA piece, and I apologize if I'm getting onto a soapbox here. You've hit on a hot button issue for me around HIPAA. Now
that was the idea to get you all riled up.
Yes, well, you did it. You did it. So now you'll pay the price. No, 20 years ago, when HIPAA security was first starting up, of course, HIPAA privacy had started before that, and administrative simplification started, in the 90s. But it was 2003, 2004 when HIPAA security went live, and at the time it was wonderful. I was a CISO at the Minnesota Department of Human Services, and all I had to do was whisper HIPAA. And I got whatever I wanted. I got budget, I got staff, whatever I needed. It was wonderful. HIPAA has so outlived its welcome. We are in an environment where we have a need to share data constantly with everyone. And if we cannot constantly share data with everyone, someone could actually die. Data sharing is just such a critical piece. And one of the biggest misses for HIPAA, at least in the security and in the privacy realm, is this focus on confidentiality of data. And I don't want to minimize data breaches. I'm not going to say that people are not harmed by data breaches. Yes, that is absolutely a thing. People can be harmed by data breaches. It is as much on the financial side of the world as anything else, and we could get into a lot. I don't want to get too deep into this, but HIPAA really missed the mark because the damaging technology security issues are not in the area of what we would call confidentiality, but in what we would call availability. It's the ransomware attack. And I often use this example. If you're scheduled for a surgery for tomorrow and your healthcare organization suffers a data breach, tomorrow you have your surgery and off you go. On the other hand, if you're scheduled for surgery tomorrow and your healthcare organization suffers a ransomware attack, your surgery is most certainly canceled. And what if you were on the table at the time of this attack? This is the critical issue. To me, that is where our focus should be. And with limited funds and limited resource, limited scope, limited ability to focus on multiple issues, I think our focus on confidentiality of data has harmed us in the long run and has set us up for these availability issues that we see right now. And I'm sure I open a can of worms here with this, but
that's what I was asking. And is HIPAA obsolete? Should there be a policy initiative driven by the clinicians and the AMA and all the other organizations and work with the legislators to say, let's rethink HIPAA?
Absolutely. About 10 years ago, I actually did a talk. I called it Healing Healthcare Security. And this was the sort of the thesis of the talk, was that HIPAA has long since outlived its usefulness. And rather, I wasn't focusing on the rewriting of the basic rules itself, but it's more around the penalties. And the fact is, we take an organization that does not have budget and does not have resources, and then they suffer a problem. And then on top of that, we're going to fine them. So they already don't have money. Now we're going to take more money away from them. And then in this new world of class action lawsuits, it's the gift that keeps on giving. It's impossible. And my suggestion in that talk, again, this is 10 years ago, rather than saying, organization, you're going to be fined X million dollars by OCR, HHS, CMS, whoever's fining us these days, is maybe the organization should have a mandate to put that spend into shoring up the infrastructure to help out for the future. And maybe there could be some matching federal funds to help out with that as well, because that's certainly a big gap. But yes, HIPAA way out long. It's welcome. I did want to make.
Looks like you've touched the button.
Yeah. It's
She's nodding her head. She's saying yes.
Yeah, a quick comment that I wanted to make. The original reason I pressed the hand button, and I have a few other comments I'll save for later. But as Deepti was walking through the care journey, Deepti, I'm resonating with every word you say every time. And maybe I know you're a CMIO, and I always felt like the CMIO, CISO. It's a very clear partnership that has to be, and maybe that's why I'm resonating with everything that you say. But as you were talking about that care journey and listing all the opportunities there, I was kind of the thing that jumped into my mind is, well, wait a minute. Most of this stuff really has nothing to do with AI. I mean, AI can help, and maybe, yes, predictive care, that's maybe a little bit more AI-like, but, meeting the patient where they are, I made a list, scheduling, maximizing interaction time, information collection, summarization, case notes, follow-up scheduling. We've been trying to do these things for ages. And in fact, I'll point back, many of you are probably familiar with the clinics and surgery center that was built on the campus of the U. And there's some phenomenal technology in that building, one of which is called RTLS, real-time locator system, that can follow literally the patient journey as they move through the building. And there were these wonderful, if you're a Harry Potter fan, and the Marauders map, I called it the Marauders map, that was sitting at all the nurses station, where you could follow the different, and we put it on badges. So you could follow badges around the building. Of course, the clinicians didn't like it because they felt we were watching everybody and, tracking how much time they spent in the bathroom or whatever it might be. But from a patient care perspective, it was wonderful. And if a patient badge didn't move for 10 minutes, somebody was supposed to go to that location and see what's going on. Did we not meet our appointment schedule, or is there some other kind of a problem? So much of what you were saying was potentially available. Could it be enhanced by AI? Certainly, in many of these cases. But if we were having trouble implementing this in the days before AI, we're just going to have the same problems now. And okay, I'll make one other comment and then I'm done. You talked about processes and lean. And yes, it's very difficult. It's process by process. But one of the problems with AI and another thing called ML, machine learning, just automation in general, is that if we're taking poor processes and just doing them a little faster, we're not getting any better. So if we can really get the processes better, maybe AI can help us analyze the processes and get the processes better, then we can speed things up through automation, and then we'll really have something going. So I'll pause there.
Yeah. I think to Barry's point, the one other thing I'll add about HIPAA is the nature of the data has also changed. So, we think of data as these, data points in the written word or natural language processing, whatever. Now data is voice, data is pictures, so I think you have to think bigger, and HIPAA is still sort of entrenched in data as the written word. And I think they are not thinking fast enough in terms of how data has changed. I mean, now take the example again back to ambient listening. We have voice files. We used to say, okay, with demographic data of, the patient first name and maybe, the zip code and all that, we can get back and identify who the patient is. Think of it, we have voice files on patients now. And, they are talking, the physician is talking. I can identify using a very simple algorithm, trace back who that patient was, if they've ever given a public lecture or spoken somewhere, on Instagram, and identify the physician. If I've given a public lecture, this lecture could have been recorded, and I can identify who I am without having to give out any other data points. So the nature of the data has changed, and HIPAA has not kept up with this.
What's your sense, Jaideep? You're the data expert.
Well, so in one sentence, HIPAA was designed for paper records, not digital records. So all the things, Deepti gave excellent examples, Barry gave examples, that we are, data today means far, far more than just the, paper records being faxed around. That's the way it always used to be, right? Fax machine. And in fact, it was funny. People said, oh, we don't email because fax is more secure. Yeah, right. Okay, so I'm going to use that comment to cue off into one other thing. That today, actually, again, having a 35-year history at Minnesota, that's, crosses more than a generation almost. So what I've noticed is very interesting, that the doctors of today or medical professionals of today are far more open to using technology than the medical professionals of 30 years ago. And partly it is just, the generational change, that people today are, those who are in senior medical positions, like Deepti is, they learned about computers in high school. And, so the idea that these are not things that are something alien, or these are, the fact that they have been productivity enhancement tools and so on I see so many people who have gotten undergraduate degrees, they're taking a few courses in computing and databases. In my database class that I've been teaching throughout, I see people coming from all across the campus, every single discipline, who wants to learn how to use SQL, if nothing else, right? So the idea is that data and information is something that is very central, and information processing in many different ways is central to our sort of existence and society today, is something that today's senior medical professionals who are the decision makers are familiar with it. And that is why there's so much of excitement about, for example, let's just go back 30 years ago. Relational databases have been around since 50 years ago, right? But their adoption in healthcare was very slow. We had to wait. We talked earlier about EHR, EMR. EHR, EMR started getting adopted once sort of Obamacare came in. while relational databases have been adopted in all kinds of disciplines way before that, but ChatGPT is getting adopted at the same time that every other industry is using it. So now the fact that this gap of adoption of technology in healthcare has narrowed, I think it is due to people, senior administrators like Deepti, who are much more tech savvy because they saw it in high school. And I think that's the big generational shift. And I'll sort of support this one by this assertion by one other domain. My father's generation was not very comfortable using credit cards. They just weren't. Okay. My grandfather's generation did not like to use a phone, or in fact, a refrigerator for that matter. According to them, refrigerators was nothing but so that you could eat stale food. But then the modern generations are comfortable using online transactions by sending credit card information over the thing. And each time the breach happens, now, Barry, coming back to the point about, let us say, big data breach happens. Okay. We always have two responses. One is a response, oh, you know what, let's go back to the old way of doing things. Or the other one is, well, let's improve security of processes and systems. I mean, right here in Target, a few years ago, we had 110 million records stolen. But that didn't stop Target from starting to use, Target cards and go back to writing everything on paper. No. So I think that we have to get out of in some sense, again, I think
It got
eventually,
them to start the cybersecurity program.
Yeah,
they didn't have
exactly.
a cybersecurity program until then. And
that
when they got
right.
hacked is when they started investing in.
That's right. And I think that, so in that sense, we always have to keep weighing the benefits versus the risks, and always keep moving forward by reducing risks. I mean, by garnering the benefits by using the technology, and the manage the risks by the kind of things that Barry does and oversees. So
But
I
the
think
challenge
those
is,
are the kind of things that have to keep going on. Yeah.
but coming back to the policy consideration, and Renben, hopefully some of these things will help us to do a follow-up discussion with Steve Kelly, so that Humphrey Institute can play a more active role. Because if HIPAA is an issue that needs to be addressed with, we need some champions in public policy arena. Um, but the question I was going to ask Jaydeep is that, um, from your vantage point as technologists, as you've seen these systems develop, do they take into consideration the HIPAA limitations and restrictions that are imposed at the point of care? How do you see that being different? Because obviously what we are saying is that AI is then ushering in a new frontier. We have a unique opportunity to rethink how we do business on an ecosystem level.
Yeah.
An integrated approach upstream rather than downstream, right?
Yeah.
So how do we bring these pieces together?
Okay, so since you mentioned about HIPAA and the solution providers, let's take two specific examples. Let's take Cerner and Oracle, and then Epic. Okay, so Cerner was designed as a health information management system. Oracle has bought it, right, a few years ago. Okay, and when Oracle thinks about their technology, they don't even think HIPAA, because they are a generic database technology.
Yeah.
But when they're putting Cerner on top of that, then they're saying, okay, well, Cerner needs to worry about HIPAA. So let us say, how can we go ahead and use the basic mechanisms that an Oracle provides to be able to map all of that? So that's sort of, it's sort of different levels of mapping. So they're worrying about it. Epic, surely they worried about it from day one, because their focus always was healthcare. But what is happening, I've noticed, is that going back to the fact that HIPAA is all about paper records and their digitization. In fact, if you see, rise of Epic is literally after Obamacare, right? That the digitization of records and in hospitals, that's where Epic really took off. So last 12 years. The point is that because HIPAA regulations are essentially designed for paper records, which now have been digitized, that part is applicable only to that. The part about the ambient listening and what is being generated from that, I don't think they're even thinking about that. They might be thinking about it, they're not doing anything. For example, this ambient listening example that they actually gave a live demo here at, in fact, at Humphrey Institute, we had, a month ago, a session where 2 or 3 of them came and gave a demo. What happened? The data came in, it got collected right there. It was sent over to Microsoft Azure, which sent it over to maybe OpenAI. And is there a HIPAA chain that is being followed? I don't know. I don't think so. So the point is, does HIPAA even talk about custodial chain of custody the way blockchain talks about it? No, of course not. So the point is that it is all about, well, this information is stored over here in one system, and who can have access to it? That's what HIPAA is all about. It is not so much about, well, so some of this data got collected. Now, the question is that part of the conversation, an ambient conversation, can be about, well, how are you feeling? Health part. The another part of is maybe about, how did the Vikings do, or how did the, Timberwolves do? Which part of it is HIPAA controlled? No one is analyzing any of that. So, and it's not so easy. So the question is that when ChatGPT or that OpenAI technology they're using through Microsoft Azure to in real time analyze that and create some kind of a user level summary, patient level summary, something like a doctor level summary of ambient conversation, which is HIPAA compliant, which is HIPAA controlled, and which is not HIPAA controlled. No one has any clear direction on that. And that is where I think that the policy people, those who designed HIPAA and are going to update it, they need to step in and take charge of that and tell us, the technologists and the hospital people like Deepti, who has to work with it, and people like Barry, who have to make sure that it is updated, that it is controlled appropriately, HIPAA controlled, and to us as technologists as to what we can do, what we cannot do. All of these things, I think this is a time I've heard in many different conversations that HIPAA needs to be updated. We're not seeing any action on that. And I think there needs to be serious action.
So that's an opportunity for someone to take the lead and make this into okay. So Deepti, I'll come back talking about policy. You are plugged into this 12-member congressional team that's looking at AI laws or whatever guidelines. Tell us a little bit about that, please.
So I don't know anything from the federal level, but there is a bipartisan team that has been appointed at the federal level to inform ONC and HHS, basically ONC reports to HHS, around AI policy. Now, AI, currently the policy landscape is so bizarre because what I call, several cooks in the kitchen, and I don't know who to look to for policy. I mean, so FDA has a role, FTC has a role, FCC has a role. The White House is putting out policy statements, which is sort of bizarre to me. And then the states themselves are creating AI rules. I mean, currently in the California state legislature alone, there are 44 bills around AI. I mean, so it's sort of no man's land, and everyone's is catching on to AI as a buzzword and not really thinking about how do we create policy that's sort of global and applicable and practical. So apparently there is a 12 members from each, 12 Republicans, 12 Democrats. This group has been created to sort of guide policy creation so that the appropriate bills at the federal level can be introduced. And how I got tied into it is a representative from Orange County, where I live, is Michelle Quant, who is one of the members. And she has locally created another team to inform her as to what she should take back. And she has created this team with, one member from representing healthcare, which is myself, people representing supply chain, there's automobile industry, bankers, all these different people who are representing different areas where AI is becoming very front and center to inform her, which she then takes back to the federal level. So that's the synopsis of it in a nutshell.
Okay, it's evolving, so we don't even know if there'll be one coherent policy or there'll be for individualized.
Exactly, and the ONC actually has just gone on a limb and appointed a chief AI officer who will inform HHS is my takeaway from that. But I don't know what the exact role will be. Will it just be as it applies to healthcare delivery? Will it be just global healthcare and regulate the healthcare industry? Because we work with a lot of third parties and things in healthcare today. Technology drives a lot of healthcare. So I don't know what that flavor will look like either.
So it makes sense that ONC oversees the whole process of, they talk about integration and data
Right.
integration. They were the keepers of investments in Epic or in Cerner at that time. So Mickey Tripathi has appointed someone who's the chief AI officer, you're saying.
Yes.
Okay. Worth following up. Jaideep, um, tell us a little bit about how do we link all of this to the medtech sector? Because this conversation so far has been pretty much focused on the care journey, the patient, and going out from there, that being the bullseye, right?
Yeah.
Again, if you were to do.
Yeah, so a little bit about the medtech sector, of course, as all of you know, Minnesota is big in medtech. Everyone knows that. And actually, let me just, since you mentioned Gopal, let me mention a little bit that what's going on here is that, last year, a year ago, the White House came up with this thing called, part of the Chips and Science Act. They talked about, then they instructed Department of Commerce and specifically the EDA, Economic Development Authority, to come up with a tech hubs competition across the nation. So just about a year ago, something like almost 250 teams from around the country, they submitted these proposals to designate it as tech hubs in different areas, from clean energy to autonomous vehicles to all kinds of things. This region submitted one on what they called MedTech 3.0, and we were one of the 31 that got designated as tech hub. So officially, the Department of Commerce has, designated this region as a MedTech hub. We are the only ones in this area. There's others in like pharma and so on, but not in MedTech. Okay. So what does that mean? So basically, and the definition of MedTech 3.0 was basically smart MedTech, which means AI, data science, machine learning. That is pretty much in the statement. And using that as the, so the future or the next generation MedTech is going to have a lot more smarts, and smarts in a couple of different ways, from whether that happens to be medical devices that are made by Medtronic, for example, they will have a lot more smarts in them, to all kinds of decision tools and so on that work with data coming out of medtech. And again, it could be special purpose medtech or commercial grade medtech, or I should say health grade medtech as Medtronic does, or even, let us say, data collected from generic ones like an Apple Watch, right? So it's the smart medtech here means both the devices becoming smarter and the decision making using information from such devices becoming smarter. So that's a big thing that's going on, and that is where AI is a big one. And then recently, of course, this MedTech 3.0 consortium has been formed, headed by the Greater MSP, the organization. And then it involves, of course, University of Minnesota, Medtronic, Mayo, Medical Alley, even the various hospitals here, from Alina to VA hospital to, and then, even then our insurance providers like, Optum from United Health and so on, and Health Partners Institute. It's like a whole spectrum of organizations that are working together. Now, in that background, to answer your question, Gopal, I think that is use of, so medical devices are not being seen just as devices that provide therapy. for acute conditions, chronic conditions, whatever, but also as data generating devices, right? And how can that data better help the medical well, one is on the very first side, it is how can it better help someone understand their own life. So like my Apple Watch tells me a lot about how my body is doing, right? And so therefore, for my own sake, and then the other part is that it provides information to my provider at various levels about, it could be my health and fitness coach. It could be to my yoga instructor. Not that I have a yoga instructor, but, to anyone, right? To my dietitian, to my anyone, right? I think my spouse would love to know how much I'm eating of all kinds of things, sure. She always thinks I eat too much sugar. So, the point is that these devices are now data producing devices that can help better understand someone's life. And I think coming back to, deeply to the point of that, one of the early points you made was that we have to think in terms of patient centricity and not, let's say physician centricity or someone like that, right? Or even a health organization centricity. And I think that is where a lot of interest in the so medical devices is being used in a much broader sense. Earlier it was, some implantable that Medtronic creates and so on. That's where it started. But now it's, everything that is capturing all kinds of information about our lives. And a couple of other concrete examples I already gave you with the CPAP device and its usage in the home. Yeah.
Thank you, Jaideep. Quickly, Renben, you raised your hand, so please go ahead. And I know that's 7 minutes to no, we have time. We have time, right? Okay, sorry.
Yeah.
Go ahead.
Yeah, I just want to go back to some of the comments that have been made. I also have a lot of opinions and also research back on data protection. We can have a separate conversation on that. But also, I think there's a lot that's been covered about how AI, the applications can potentially improve efficiency and augment the tasks that the current clinicians are doing. So one question or one point that always comes back to mind as a policy researcher is always when we see all these AI harms and AI incidents that are occurring. One thing is, as all of you have mentioned, there's a lot of AI buzz and AI hype. Is everyone's rushing to adopt AI? But the question that people need to always ask is it truly necessary? And I think, Barry, you captured that. You mentioned that. Is this, and I think to further that question, because this is healthcare, is also to ask if this technology is going to enhance the human experience, because this is all about care. Is it truly going to enhance the care in the healthcare? I think a lot of people rush out to increase efficiency, and I'll bring up an example that I thought was really great. There's this project actually in Minneapolis called Mapping Prejudice. I'm not sure if you've heard of them, but they are this initiative that's analyzing all the land deeds, historical land deeds in Minnesota that contains a lot of racist languages, and how that has impacted our current the urban planning, how the city is distributed, and a lot of the other public services, how that's been affected by all these racist historical land deeds. And so what you're doing is a lot of their work is processing a ton of text, a ton of document, a ton of data, essentially. And this sounds like an ideal job for AI to process these and map it out very fast. However, this project, they decline the use of AI, and I thought this was a great example of how this is a situation where AI may not be necessary, because they say that a lot of your work is actually done by volunteers, and they are volunteers that are going and analyzing these documents that are learning about the historical, the racist history of Minnesota and how this is impacting us, impacting society. So that becomes the human experience in itself. And if we were to use AI to replace that, which it could very easily and make it very fast in mapping out all these land deeds, but it would take away that human experience and to take away that enhancement on what we could potentially learn. So I think, and this I think I can see a lot in healthcare, how when we talk about, remote care. It can definitely help a lot of clinician who has, burnout, and how they're going to address patients, how can they help to not to lose sight of, is this truly going to, enhance that care perspective in healthcare, since human is essentially the main point of healthcare. And we always talk about how we want to design, AI that is human-centered. I think this is a very relevant topic in healthcare. But also, I think we also have to think about the AI researchers, people who are developing AI. They're essentially also still, still humans, and they can make mistakes. I think back to this recent workshop that I went to, that where an AI professor was presenting their research on how to, increase efficiency scaling up in AI. And just a very basic question of, where did your data come from, and how do you understand the processing methods? And the professor was unable to provide an answer. It does showcase that there is still much to be sort of improved, to think about where these AI models are coming from, who is developing them, and what they're thinking about. Because I think this is where Dipti asked a great question about the percentage. Is 80% good enough? Like when we talk about accuracy, 80% does sound really good. But when it comes to safety outcomes, or potentially outcomes that can implicate rights and liability, is 80% good enough? Is 90% good enough? So we look at all this example, and I think about this system, which is highly reported about the criminal justice, where the company claims over 90% accuracy, but accuracy on whom, and who is accurate, the outcome is accurate for, and is that sufficient in a safety environment, in a healthcare environment? Maybe it sounds like it's not at this moment, because we see all this, companies hyping, oh, we have over 90%, but maybe that's not good enough yet. And I think this is especially also when we look at using AI to predict human behavior. This is where it can get really tricky, and some of you mentioned the application in that, and it makes me think about how there's been a lot of good intention in predicting human behavior, but it can get really tricky. And this reminds me of a case also in Minnesota, where the government tried to implement a human prediction algorithm on troubled youth, where they want to target them earlier to help prevent them from ending up in prison system. But then, I don't know if you heard about it, but this project went sideways really fast and was given a nickname Cradle to Prison, because they were targeting a very specific group of youth, and coming in, they went in with good intention, but it did not fall well. So it's also thinking about the outcome of whether or not what we envision for AI application, and how that could potentially turn out. So this is where I think a lot of risk assessment comes in, and it sounds like a lot of governance work, but we can't say enough, like we need continuous monitoring, continuous reporting on how this is faring. And I always point to the Right 8 case. I don't know if you heard of it. It became a huge case, and FTC is dealing with that. I think they're being fined a lot of large amounts. Some is essentially a Right 8 implemented a facial recognition system to identify shoplifters, again with a claim of accuracy above 90%. And again, they were targeting people of color, women, ethnic minorities. And so a lot of this was, when you go to check what exactly happened, there's not enough monitoring, there's not enough testing, and scaling up the application too quickly to all of their branches. So I think it comes back also this, where I want to say that human oversight is extremely important. And this is, again, healthcare. I know that there's a mention of physician burnout, but at this point, I don't think it is possible to go without human oversight. No, like even if we think, radio imaging, like AI imaging is getting better at accuracy, but there still needs to be human oversight to ensure that what is being relayed to patients is, ultimately worthy. Yeah.
Makes sense. Dipti, if I come back to you for a second and ask you to just sort of synthesize what's going on today in terms of in the marketplace, organizations, associations, industry groups, focusing on the patient centeredness and seeing AI from inside out. are there meaningful efforts going on, or is it something that just is
Well,
getting
I think
missed in
there are
the
too many
shuffle?
efforts. I think there are too many efforts going
Okay.
on.
Mhm.
So I think every vendor, whether it's an existing vendor into the healthcare ecosystem or outside, net
Yeah.
new, they're all dabbling in AI. I mean, right now the buzzword is AI. So even when they are pitching or we are renewing our contracts or whatever, I mean, just as an example, in any healthcare system currently, the number of applications we use is somewhere between 200 to 250 just for care delivery. I'm not even talking about supply chain operations, all of that. Just for care delivery, we are using about 250 or so on an average applications, of which the EMR is the largest application, but even beyond that. And every application, I've done sort of a crosswalk. 80% of these applications now have an AI component. So, and all these companies are rapidly developing, AI components to everything. So, for example, we had an application to deliver training to our clinical workforce. Now that application has an AI component. What the AI component does is, sort of does the curriculum development for them and sort of publishes that curriculum and then creates bite-sized pieces. And they say the bite-sized pieces are easier to absorb. So that's just an example. So there's a lot of AI-driven solutions that are coming our way. What we struggle with, even with, we have set up an AI governance, so where internally we vet all these vendors, and we have a key tenet of human in the loop. Everything has to be a human in the loop. We don't know what they are telling us, whether we can take that to be the truth. Because one, like you were saying, we don't have visibility or transparency to the algorithms that were used to develop those algorithms. Secondly, we don't have confidence that those algorithms can be applied to patients in our ecosystem, because again, we know that the patient populations vary from region to region and from location to location. And then the third problem we have is, how do we build trust among our own internal users that these systems are good enough? So the trust, transparency, the usability, the algorithmic development, and then how do we manage? I mean, this is going to be a huge problem down the road. We implement something today. How do we know that the model is not deprecating? Well, we are an academic system. We have, data scientists who can do that, but not every system has that. So how do we know that the model is still functioning 1 year down the road the way it was developed? How do we know that the model still continues to serve us well? How do we know that there are no data leaks from that model and no secondary gains are being made from that model? So all these things are things we grapple with. This is, I mean, for us, because we are a large, UC system, we have very robust governance systems, but I can see, small mom and pop healthcare shops or, smaller systems that are, just sort of care delivery systems without that academic and research arm grapple with this and not even think about it. That is where I think regulatory oversight is very important, because if you're not thinking about it, you're already losing the battle.
So, Deepti, the vendor community, if I hear you correctly, you're saying is developing their own solutions, and
Right.
everybody's pitching, and they have a message that this will work, patient-centeredness or whatever, right?
Right.
The solutions might be. You're not sure if it'll work, one part. Second one is there are multiple vendors, they're all coming in, right? Either it could be just hype, or it could be a real solution. That's something for the buyers to assess and determine. So is there even an appetite out there in the marketplace for the vendor community to work together to have take a standardized approach? Is there a standards? Because I remember once sitting on President Obama's team on standardization. This it was led by at that time the chief technology officer, and we basically talked about standardization, and that dream has never.
Yeah, and
panned
I
out.
think it's going to be very hard because, I mean, let's take the Gen AI, sort of hype in itself. Every vendor is using either creating their own Gen AI model or using, one of the established Gen AI models without stopping to think if that model is actually the best model for even their own use case. So that's why I'm saying it's the Wild West, because I think, one, we have the regulatory side, but I think the vendor community is not stopping to think. They're thinking about the solution and the use case and the advantages, but they're not stopping to think of the ethical and the trust implications that these tools will have down the road. You know, so I think that's where the gap comes in.
Jaideep, as a technologist.
Yeah, a number of points have been made. So I'm going to address, let me start from the very last one, Deepti's point. Vendors are playing in a for-profit situation. So competitive for-profit. So it's in their best interest to create vendor differentiation. When in the database literature, or not in the database industry, everyone had their own database language till SQL was standardized, and there were all kinds of fights that happened about that. I saw those when I was a grad student out on the West Coast. IBM and Microsoft and everyone kind of duking it out. Informix, whatever database. So expecting vendors themselves to come up with standards is just not going to fly. A big vendor will say, "Oh yeah, what I have should be the standard," right? And then the next one will say, "No, that should." I mean, there's no way that Microsoft and Google are going to agree that this should be the standard. It's just not going to happen. So it has to come from whether it is the government through NIST or whoever has to lead that effort. So that's the vendors are not going to do it. Now, some of the other points that were made about, let's say, is 80% good enough, accuracy and so on. I'll actually make a couple of points over there, maybe one of them controversial. So the thing is that I think, first of all, that all these tools should not be seen as that, okay, we're going to use this tool instead of using human doctors anymore or other, right? These are all aids. So the question is, if it says that, if a tool has 80% accuracy or whatever it does, it points out something, says, well, these are the ones to focus on, okay? And so it's an aid rather than a decision-making tool. Having said that, I'm actually going to take another thing. How much do we know? How many of you have ABS in your car, an automated braking system? Do you know what the accuracy on that is? No, and you don't care. You are actually putting your life in danger on the accuracy of your ABS system working. And many of you live in Minnesota, and those who don't have lived here in the past. So every time you're driving in the winter, an automated braking system is taking care of that, right? How many of you do you know the accuracy of your credit card's fraud detection system? You don't. Do you care? So one of them puts your life in danger when you're driving in Minnesota and the snow. Another one puts your life in danger, well, your financial life in danger with a hack. But the question is, do you know and do you care? So I think this whole business about how accurate a model is, and I hate to use this word, is a little bit of a red herring. I think that yes, those things are very important. The patients will not necessarily care, but I think patients care about the trust factor is extremely important, obviously. So I think that if these tools should be seen as one that will make the care provider's job easier, okay, help them spend more time, be better informed and spend more time with the patients so that the decision making and the care giving can be better, as well as the trust building, which is, and the care provisioning becomes better because of more face time, more contact. So the doctors can, and other care professionals can go back to being what they were before they got dragged into record management, right? Or typing in this, that, and so on. So I think that that's the way we have to look at it. And then the question of what trust, eventually what will happen is that it's going to be a generational issue. The next generation is going to start trusting the use of many of these devices and their things far more than the current generation. And the generation after that will that. In fact, the best statement on that was, I remember once talking to the chief privacy officer of Facebook. This was many years ago when they were called Facebook. And I remember asking a question that, what is Facebook's stance on privacy? And his answer was really interesting and very telling. He said, well, let me think about it. Let me word it carefully. And then he smiled and said, Facebook's stance is to always remain just a little bit on this side of the ever receding frontier of privacy. This is, we don't want to step over it, but we also realize that next and younger and younger people don't care as much about privacy, because like Facebook privacy is, well, my mom and dad don't know, but the rest of the world can know. So again, I'm sort of not being facetious in this. I'm just talking about that the concerns about decisions being automatically made and so on, we become concerned about those when we are behaving like experts, right? We have a bunch of people here all have either medical experts or medical policy experts and so on. So we think about privacy of those or accuracy of those models and so on. But when we go back into our regular lives where we are interacting with the world in areas where we are not experts, and I gave the example of credit card and ABS systems, we don't quite think about it. So that's the way patients will think about it, right? When someone is playing the role of a patient, which everyone is, that's the way they will think about it. They will trust the medical professional, and eventually they will trust these algorithms and devices as generational changes happen. So that's sort of my overall sense about this.
But Jaideep, isn't that a correlationship between improved accuracy and one assumes that it's zero defect. One assumes that it'll work, and that's because time has elapsed. So there's an element of assumption as well, isn't that true?
Gopal, zero defect is a marketing statement, not a statistical statement. It's a great marketing statement.
Yeah.
And those Japanese who came up with the zero defect cannot prove anything. No one can, because it's math. So anyways, I mean, yeah.
Zero trust, like Barry.
Zero defect. Yeah.
Yes, a
No,
couple
but I
of
think the
comments on
point
that.
is, no, those accuracy stuff is extremely important for people like this, right?
Yeah.
That is, yes, okay. So someone like Deepti in her job as a healthcare administrator has to make a decision. Is 80% good enough, or is it 90%? Is 95%? And that's where and then what is the risk? What is the benefit? So some kind of overall risk benefit analysis has to be done. If it's 80%, well, maybe you need, at least 2 doctors to look at it, or whatever it is, right? Some kind of thing like that. And if it's 95%, 98%, well, most of the time you can say, well, if it's minor cases, I'll let it go. So the point again is, let's say, even remember, every single instrumentation, Deepti, you tell us, breast cancer screening, it doesn't have 100% accuracy. It's not zero defect. And in fact, there have been cases where even doctors made mistakes, right? So no decision making is as I said, zero defect is a marketing statement.
Yeah.
So all instrumentation, whether that instrument happens to be a machine, an AI, and radiology imaging, or a human, all the decision making machines, if you will, they all have some errors. Okay, we are more comfortable with humans, and therefore these devices should all be seen as aiding the human, because then we can build trust, and that's it. That's my view on it.
I think we've come a full circle in which the first point that I started with, which is education.
Yeah.
And I think, coming back to your point, Jaideep, we articulated it very well. Yes, all these diagnostic tools have a margin of error, but we have taught our clinicians that from get-go that, yeah, you still need to have oversight, there is a margin of error, all of that. We have not taught them in the same manner around the new Gen AI tools. And I think that is where we need to go, because, if we don't do that in the right manner, then that mistrust will always exist.
Gary, you raised your hand earlier. You wanted to say
Yes,
something at point?
couple of quick comments on this. So I love, Jaideep, what you were just saying, and I always put it with folks this way, that when we talk about the use of AI, our goal is not to outsource our brain to an AI, but to be able to use an AI to augment what we can do. But on your examples, so your example of ABS braking systems, fantastic example. I'm gonna use that example in the future, because that was an absolute wonderful example of how we have completely outsourced our brains to an automated system, and we don't even think about it. It's a wonderful one. But thinking about the one around financial fraud and the financial systems, there is such a huge difference between the world of financial services and the world of healthcare. And when we think about whether it be fraud detection or whatever it might be, in financial services, right, they've got clear financial motivation. Now, yes, we do in healthcare as well. We have financial motivation, but in financial services, they also have the financial resources, and that is an area that we certainly lack in healthcare. But maybe one of the biggest pieces, and we think about generally obstacles, and I know we want to be optimistic here and think about opportunities and ways forward, but we have to recognize the challenges. And in financial services, a financial service organization, without being overly generalizing here, they're a fairly monolithic organization. Virtually every person in a financial services organization has more or less the same job, and they have just a few handful of systems that they work with. Deepti before mentioned 200 to 250 systems on the care delivery side. I would argue it's a lot more than that, and we often talk about it as application proliferation. There are so many applications in healthcare, and we suffer from what we call technical debt, because there's never enough money to go around to update everything. So we have a lot of old technology that we're dealing with. And then when something like Gen AI comes out, and everybody wants to go 1,000 miles an hour and off one direction, that our technical stacks are just not ready to be able to handle that. So it's a huge challenge across the board, and it doesn't all come back to money. This is not something that you can just throw money at and solve the problems, but finances and resources and training and everything that goes into this resource bucket is absolutely a key challenge, and we do need help there in healthcare.
It reminds me of the time in 2008 or thereabouts when, again, the emergence of the EMR systems, etc., ONC was established and serious amount of funding was made available so those systems can be implemented. Are we seeing something similar, train moving in that direction? Because this is a new frontier, just as EMR, EHRs were in 2008 timeframe. Or Deepti, what do you think? You're there in the system, and systems are always strapped for resources.
Yeah. So I think there is funding. There is also a lot of this is very early stage, and there is, like systems like ours, we have a lot of co-development opportunities, which gives us a lower price point. We are partnering with Microsoft, AWS, all of them, in terms of studying this together. However, there are a lot of grant opportunities right now, like FCC is putting out AI-related grants, so is ONC, the HRQ just put out another grant opportunity. So there's a lot of money coming this way. There are also CDC AI grant opportunities. But again, remember, these are opportunities just for large academic systems that are looking to study. I don't know what is happening, because this is a very unique setup where working with the tech community, the vendor community, is going to be so important. And if systems are just studying this internally, with their own data, studying AI, machine learning tools, or, developing their own LLMs internally, I think that is a missed opportunity, because we have to work very closely with our vendor partners on something like this. And as soon as we say we work closely with our vendor partners, then those funding streams dry away because that's sort of a conflict of interest right there.
Jaideep, you're plugged in on the vendor side. What are you seeing in terms of these big, of course, the big players, and then the innovators? Because again, we don't want to stifle innovation. Is the VC community putting in money? Are you seeing any activity?
So let me first start with the vendors. Okay, so clearly, I'm watching two kinds of vendors. One is innovative companies, right? So there are lots of small companies who are taking some particular aspect and then doing something with it. Just let me give you a couple of examples of things. So for example, some people who spun out of Alina, for example, over here, they're working on how to better use data that is collected from various surgery schedules and then use AI to figure out how to better optimize surgery schedules. Okay. Someone else is working with the dental system and saying, well, each time someone misses a hygiene appointment, there's a loss, and they don't have to pay anything for it, so they just miss it. And that's like has been stated 22%, 23% throughout. So how can we use AI to better predict who's going to show up or not show up? And that deployment of that has actually shown um, a huge amount of benefit in doing that. So there are innovative companies, even small companies to medium companies that are doing all of this stuff. And in terms of core AI technology, they of course are too small to build their own core AI technology. So they're just tapping into whatever core AI technology is being done. Okay. Another one is using chat GPT kind of technology for better patient communication and so on. Okay. But the other way to look at is, what is someone like Epic doing? Or what is someone like Oracle Cerner doing? Since they have, the inroads into all the hospital systems. I already gave an example of, with Epic, what they're doing, and they're moving forward. The huge number of projects that Epic is involved in applying AI in all kinds of things with the EMR, EHR data, and in the medical system, in the hospitals, they are very bullish. So, and if any single organization can have the maximum impacting these kind of things, available tools and impact of AI available in in the operations of hospitals, they are the ones. They are the best position right now. So I would say, and of course, Cerner is doing the same thing. In fact, Oracle actually keeps saying that, oh, look, we understand technology far better than Epic does. But Epic has partnered with Microsoft. So it's interesting that's going on is that I think that the AI is going to come into the hospitals through EMR, EHR systems a lot more and integrated into their systems. And very often, as many functions where AI is completely embedded, it's not even visible to people. So I think that's where, Deepti, it might be useful also from your perspective
Yeah.
that you don't have to manage 200 different systems, right? It might go from 200 down to maybe 20 because a lot of functionality comes integrated with Epic. So that might be maybe a solution to the problem of huge heterogeneity that
Yeah,
you have to
but
deal with right now.
But going back to the cost thing, none of that drives down cost. So Epic is passing on all that co-development cost with Microsoft to the health system. So we are paying, I mean, we are using ChatGPT with Epic, even though we are a co-development partner for ambient ordering, chart biopsy, summarization, all of that. We pay a per token cost to Microsoft for that. It's not like it's part of our Epic suite of offerings. So really our cost of using the EMR has gone up, even though, so then what will happen? Where will that cost be passed on? It'll be passed on to the consumer. And the healthcare system already operates on a very thin margin. So I think if you look at the big picture, none of those tools that are being offered through the EMR, which I'm glad Epic is working on that, none of them are actually, they're actually affecting our bottom line, which makes us hesitate sometimes. So even if I go out to my CFO and say, hey, there is yet another tool from Epic using ChatGPT now, he'll say, how much more is it going to cost me? And it's a no-go at that point.
I think the solution to that one is to offer competition to Judy Faulkner. She has way too much control.
That monopoly is
maybe,
getting out of hand. Yeah.
Exactly. I think it's basically a monopoly. And I don't know, maybe at some point there might be, well, either Oracle Cerner will be able to catch them, or maybe the government should step in and say, well, you guys are like Bell Systems or AT&T. So now we need to step down and, break it up. So something like that has to happen. Otherwise, I think that their power of being able to charge whatever they want and pass on all the costs is mainly because of the market positioning. So I think that's given our the way the industry works, that's exactly the solution to it too. Have competition. Yeah.
Yeah.
Maybe some more people should, some more hospitals should. I keep seeing news more and more that 10 more hospital systems have decided to go with Epic. Maybe half of them should go with Cerner.
Cerner doesn't offer the same sort of
Exactly.
solution. So,
So I think it's the
Yeah.
you guys are suffering from. I mean, I can say from a hospital system perspective, you're suffering from the what is it called? Economists have a name for it, right? That it's like the boiling of the frogs, if you will.
Yes,
How
that's
do you
true.
boil a frog?
Yeah.
Keep
And
raising the temperature a little
actually,
bit at a time.
Judy herself has said they would love more competition because it keeps their own staff, at their
Sharp.
on their heels innovating. So because right now they have become complacent too.
Yeah.
Well,
That's right.
this has been a very exciting conversation. We've got 5 minutes, 4 minutes left. So, a couple of things. One, we have recorded this conversation, and I hope it's okay by all of you. We did check with you in the past, so I appreciate that. This will give us a chance to re-listen and try and synthesize. I've picked up a lot of nuggets today. I'm not sure if you people have had some new learning experiences, but there seems to be what I'm hearing is HIPAA needs major work. Privacy policies. Barry will probably agree that Minnesota's privacy policies go back to 1974. If I remember when we were setting up the cyber security group at the state. So there's a trust factor we talked about. We talked about standardization. And again, I know that in 2008, I was part of that White House Committee on Standardization when the Epic and Cerners were coming of age, and nothing happened. So I think there needs to be some renewed efforts based upon the past experiences. I think there's an adoption issue that you talked about. I think the education piece was very interesting because the sooner we get the learning process started, the better the adoption will be. And I picked up a lot of today. What about you guys? If you can just take 30 seconds each to summarize and synthesize your take on this, and who you think we should be including in the next round of conversation that you would like to see. And this we want to do, make it exclusive, so there is more discussion, drill down, nuanced conversation as opposed to the sales talk.
I can take I mean, I think this was really, very, very engaging. And I'll start with saying misery loves comfort. So I live this on a daily basis, but I am so happy to see that others are thinking about the same thing. So thank you so much for, reconfirming what, I sort of was thinking in my own silo. But I think in terms of who else to engage, I think I would love to see some legislature representation here, because I think we really need to know what they are thinking. In terms of, or what they are not thinking, maybe we can guide them. I think that is a gap here.
Okay. Jaideep?
Yeah, no, it's really, really useful to hear, and always like forums like this where everyone comes from a different background than my own, because I hear enough of the echo chamber that I live in. But so especially Deepti, the healthcare perspective is always so important, and because that gives that is the environment in which whatever technology is developed is going to be deployed. How these technologies get deployed to the end user, I think Apple has already figured that one out. They don't need any more guidance, I think. But anyways, I think that's the. But I think the point that you made right at the beginning, patient-centric. I think that's very, very important. And so I learned a lot from various different perspectives, and and Barry, your perspective on the importance of security. And I think some of the issues that came up was that, I mean, HIPAA is only about part of the data that is collected about people and is dealt with. All the other kind of stuff we don't even know. We are collecting all that data, but what are the regulations for that? And therefore, we can put in all kinds of mechanisms, but what policies should guide them? And if the security policies are not known, then mechanisms are kind of useless. So all of that, and then when you point about policies,
very quickly, 30 seconds. Don't want to go over, and I respect your time. Any comments?
Yes,
Anything?
wonderful discussions, and I appreciate all the insight here. I like what Deepti said about hearing from others, and that the problems are universal. When we work with CISOs, I always say to them that part of the service that I and my peers provide is group and individual therapy. So I think we accomplished a little bit of that here today. But certainly more questions than answers, and I think that maybe that's part of the goal here. And Gopal, you were talking about the ability to summarize. If we only had maybe an ambient digital scribe or something like that that could go ahead and summarize all our discussions for us, wouldn't that be wonderful? In terms of who else to bring to the discussion, I echo the idea of bringing in someone from the legislative side. It would. It's a fine line. It would be interesting to hear from some vendors on what's going on, but I absolutely agree that we don't want any commercials and none of that. So we might have to dig into that a little bit more if there's another way to do that, or maybe that's Jaideep's role to bring that information to the table. But otherwise, thank you everyone. This has been wonderful discussion.
Yeah, I'll just jump right in. So I echo a lot of what Barry's saying as well, and everyone has mentioned. It's been a really insightful discussion. I really appreciate it. I think it further reinforced my confidence that there has been a lot of ethical and policy framework that has emerged from governments and also international bodies, which can be really helpful despite the lack of regulatory standards at the moment, and how to start thinking about how to operationalize them. Just for example, the NIST risk assessment framework, I think, will be really helpful in vetting, for example, vendors. But I'm also thinking, so in terms of participants in the future, I think there are a ton of civil society organizations within the space of responsible AI. I think to hear from them would be incredibly insightful as well.
We'll get back to you on that. And Ikram, do you have anything to add quickly?
Yeah, it's a great discussion from my side. 2.1 on the policy. I see that the policy side is still lagging, and with the mentioning about California, more than 44 bills, so fragmented. I think there's a need more holistic and comprehensive view, and go with that point of including legislator into this kind of discussion. Second is on that the funding and the bottom line of the hospital system when they try to implement such AI models into that. And as with health system, they're not doing great with the current revenues thing. So we need to figure it out that how funding will be happening for this kind of innovation and how they are impacting both in terms of investment and as well as the cost saving thing. That need to figure it out, and might be we can include some funders as well in the future discussion, understanding their perspective.
Yeah. And actually, that's one part I didn't mention. So maybe a couple of other disciplines that come to mind is someone who's an expert in health risk. Since we talked a lot about, risk, and especially someone who's looking at, risk due to AI or whatever else. So I think health risk, and maybe, since if there's a health economist, I don't know if there's that part, plays some role. That means, if in the whole, like we've talked about, it's not reducing costs, so where the cost benefit things are. So those couple of other perspectives might be useful in this forum.
One quick question, Dipti. There's a lot of research done and funded by government to find new cures. But is there a need for more funding for research to find better way of delivering care?
I think PCORI does that. So PCORI is sort of that organization that does a lot of funding.
Is that enough? My question is that enough? Are they, because of AI coming in? And
I think the more research we do, the better off we are. So definitely the current funding mechanism is not enough. I mean, we are still doing research in the typical, lab molecular level, which is also necessary. But absolutely, we are not doing research in terms of even studying healthcare economics. I mean, I think that there is so much that we can do more. I mean, we have still not solved the problem of did EMR save lives? And they've been around for, 30 years now. That research has not gone anywhere. So I think there's always room for that. And I'm sorry, I need to drop off because I'm late
Thank
for
you
my
so-
next meeting, but this was great.
Thank you so
Thank
much.
you.
Yeah.
Yeah, thank you.
Thank you all.
Bye.
Thank you very much.
All right.
Thanks, everyone.
Thank you.
Bye.
Oops,
You did?
I shouldn't have.
Yeah, that's my system, so I need to save that, all that.
Oops.
No, yeah, I will see.
Huh?
I will see.